Hi, everyone. Welcome to the 2021 Care-Based Incentives Spring Refresher. My name is Jo Peary, and I will be your host this afternoon. As I mentioned a few moments ago, I did add a couple questions into the chat. We would really love your feedback here and throughout our presentation today. We'll go ahead and get started. Before we begin with our presenters, a couple of housekeeping items I'd like to address. For audio, GoToWebinar, the platform we're using this afternoon, defaults to using your computer's speaker system. So if you would prefer to join over the phone, just select telephone in the audio pane on your screen, and the dial-in information will be displayed. In order to have a robust Q&A session after today's presentation, we encourage you to ask questions throughout this webinar and submit them by using the questions pane on the control panel. We will collect the questions submitted and have our presenters address them during the Q&A session at the end of today's webinar. Many of you know Oscar Sanchez, and today he will be your contact for any technical issues you may experience. His email address is osanchez@ccah-alliance.org, and it's on the bottom of the slide, so I'll give you a second to jot it down. Today we have Kristen Presley. She is a lead quality improvement program advisor at the Alliance. She has over 7 years of Medi-Cal managed care experience working on cross-departmental quality improvement and population health projects. Kristen brings research experience in decision-making and patient trust from UT Medical and Biomedical Informatics School and MD Anderson Cancer Center. Sarah Forbes began her tenure with the Alliance in provider services, and she has been bringing her wealth of knowledge to the QI team for almost 5 years now. Kim joined the Alliance last year as a quality improvement program analyst. She has 4 years of experience in various research roles, overseeing projects related to disparities in access to care and cancer prevention. Without further ado, I'll hand this over to Kristen Presley.
Thank you, Jo. This refresher webinar is aimed at focusing on a few key details presented during the fall workshop webinar, like the new and exploratory measures, as well as provide an opportunity to explore new branding, resource materials, and upcoming events. First, let's start off with where we are in the current environment. Next slide. At this moment, we are still in a declared public health emergency. Last year, there were many member outreach campaigns, including the initial emergency outreach to connect with potentially isolated and high-risk members to educate them about available resources and prevent health deterioration of underlying conditions by addressing the members' health concerns and/or barriers to care. There were also campaigns for resuming care to educate members about a safe return to their PCP and need for resuming care. Now in 2021, the Alliance will be focusing on vaccine communication, emphasizing safety of vaccine and importance of mask wearing and social distance guidelines. In addition to member support, a COVID-19 high-risk member report has been released to the provider portal, showing linked members 16 years and older who are eligible for the COVID vaccine. A flag is also included in the report, which indicates if the member is in a high-risk population to COVID-19 complications. Next slide. So here are just a couple of examples of the outreach material that was shared in 2020. One example of change in the prior CBI 2020 program is for the initial health assessment measure. The Department of Healthcare Services has temporarily suspended the 120-day timeframe for new members enrolled during the public health emergency. The expectation from the state is that the new members are still required to complete their IHA when the public health emergency is lifted. Following the all-plan letter for CBI 2020, all providers who met the minimum eligibility requirements of 5 members in the denominator received full points for the measure, and in 2021, we will continue this approach as long as the public health emergency is active. The performance improvement measure for IHA, however, still requires that the member complete the visit within 120 days or have that outreach attempts completed. One of the more notable changes in care in 2020 was the expansion of telehealth visits. Specific examples in CBI include the use of telehealth visits in the well care visits, prenatal care, and blood pressure readings. Diagnoses made during a telehealth visit for certain chronic conditions like major depression, asthma, diabetes, and high blood pressure have also been carried over in the CBI 2021 measure specifications that place the member into the denominator population. Next slide. So next on the agenda is to discuss the new measures for the CBI program. The application of fluoride varnish is one of the new measures introduced for CBI 2021. If a child is regularly seen by a dentist, the expectation is that the child should still receive fluoride varnish at the medical practitioner's office. Currently, the American Academy of Pediatrics and Bright Futures recommends that once teeth are present, fluoride varnish may be applied to all children every 3 to 6 months in the primary care or dental office. Current billing is approved for 3 times a year through Medi-Cal and twice a year through Denti-Cal for the application of fluoride varnish for a total of up to 5 times a year. One of the goals for the measure is to normalize fluoride varnish at the PCP office, since Medi-Cal members can be at a higher oral health risk for dental caries. This measure in particular will look at the percentage of members aged 6 months to the age of 5, which is up until their 6th birthday, who have received at least one topical application of fluoride varnish in the year. The Child and Adolescent Well Care Visit is a new measure from the National Committee for Quality Assurance that combines the Well Child Visit 3 to 6 years and the Well Adolescent Visit 12 to 21 years, adding in the age range of 7 to 11-year-olds. This measure looks at the same comprehensive well care visit with a PCP or OBGYN within the measurement year. As mentioned earlier, the measure has also changed to now accept telehealth visits. For billing frequency, well visits for the members 3 to 17 years of age are payable every 180 days, and well visits for members 18 to 21 years of age are payable once every 12 months. The Plan All-Cause Readmission Measure is an NCQA HEDIS measure that replaces the 30-day readmission measure. One noticeable difference is that the age group now starts at 18 years of age, and the measure will be a rate of the number of acute inpatient and observation stays that results in an unplanned acute readmission within 30 days. There are similar exclusions to what we had in the past measure, such as hospital exclusions for the diagnoses of pregnancies or perinatal stays. In addition, there are planned admissions like chemotherapy, rehabilitation, and organ transplant. New to the exclusion list is if a member expired during the stay or if the planned admission is a potentially planned procedure, such as a coronary artery bypass or surgery like a drainage, extraction, or repair. Generally speaking, there are some patterns that we see in the hospital and outpatient measures. Last year, the top 3 diagnoses for the 30-day readmissions in 2020 were sepsis, hypertensive heart disease with heart failure, and third was hypertensive heart and chronic kidney disease with heart failure. Next slide. For our next measure, there is a new naming convention from the United States Preventive Services Task Force, who adopted the term unhealthy alcohol use to replace the alcohol misuse screening and counseling terminology. The major difference here is that the measure now looks at the addition of the adolescent population. This measure will review members 11 years and older who are screened for unhealthy alcohol use in primary care settings, in addition to providing behavioral health counseling interventions to those 18 years and older. The G0442 HCPC code can be billed for Alliance members 11 years and older. However, the two LOINC codes and the G0443 code must be billed for members 18 years and older. The LOINC codes also must match the description for the code. So for example, the LOINC code 88037-7 only applies to males for the question of how often have you had 5 or more drinks in one day during the past year. These LOINC questions also match the questions that are asked on the Staying Healthy Assessment Form, otherwise known as the SHA form. One of the last changes to the CBI 2021 programmatic measures that we wanted to discuss for this year is the addition of the payment adjustment. Following changes from DHCS, health plans can receive a corrective action plan, including financial sanctions, if any of the quality of care HEDIS measures are below the 50th percentile in annual rate submissions. This minimum was raised from the 25th to the 50th percentile for health plan rates. As an update from the fall webinar, we have removed the cap requirement if a provider is in Tier 4, but the following payment adjustments remain. As part of our strategy to have more readily available information, we have updated a number of shared references and reports that allow for easier identification of provider performance compared to the percentile benchmarks. The benchmarks in red on the slide are the percentiles used in analyzing the payment adjustment. Now I'd like to hand off the presentation to Sarah Forbes to walk you through the reports that will provide you with comparable benchmark information.
Thank you, Kristen, and hi, everybody. Thank you again for joining us today. We always enjoy an opportunity to meet with our providers, so we're excited that you are able to join us. So I will be continuing the discussion on the CBI payment adjustment section of the presentation today by reviewing some of the resources that the Alliance has available for you to view ongoing CBI performance in terms of benchmarking and percentile groups. So here's a look at the new CBI practice profile, and I will review this in more detail in the upcoming slides. But one thing that I'd like to point out on the new profile is that there's a new column that we added called percentile groups, which is highlighted in the blue square. In this column, our providers have the ability to identify the quality of care percentile group for each measure, and that range matches the information that Kristen just shared on the previous slide. So another great resource available to identify rates and percentile groups is located on the provider webpage. On the screen, we've provided an example of the quality of care benchmark sheet that we update annually. So hopefully some of you have had the opportunity to review this document. Highlighted is the bottom tier of percentile grouping. So essentially we're looking at the 49th percentile and below. And as you can see, providers do not start earning points for CBI until the quality of care rates reach that 50th percentile of the NCQA benchmark. So at this point, you'll start receiving half points above that 50th percentile or that 50th threshold. Next, we have the CBI forensic report, which is located on the provider portal under the CBI reports section. So for those of you who aren't familiar with this report, the data displays an estimated number of fewer or additional visits, so it really just depends on the measure you're looking into, that a provider needs in order to receive minimum or maximum points in each benchmark group. So currently we start showing the minimum point requirements at the 50th percentile, as I mentioned in the previous slide, which means that providers start earning half points at the 50th and above. So we've asked our developers to add one more row to display the 25th percentile, and we do hope to see that change soon for our Q1 CBI report. And the last resource I'd like to share with you is also located in the provider portal in the quality reports section. I'd like to share that we did discuss this feature in our fall webinar, but just to reiterate what we're looking at for this screen is available, or this graphic is available for all of your quality metrics. So based on the quality reporting metrics, this feature allows our providers to see their performance compared to the 25th, 50th, and 75th percentile. So essentially, it gives you an idea of how well you're performing in the quality measures on a month-to-month basis. So I'll give you an example. If you're submitting your data submission tool data, you're submitting claims every month, you will start to see this graphic change. However, it really does depend on how late in the month you do submit your data. So hold tight. If you do submit it towards the end of the month, you probably won't see it until the following month. So these reports are currently in the process of being updated for the NCQA benchmark. So you may not see the rates listed on the screen at this time, but you should see them shortly. The next section that we'll review in today's workshop includes the new exploratory measures that we've included in the program for 2021. So as a quick reminder, exploratory measures do not qualify for payment, but data will be available on a quarterly basis for you to track your members' compliance throughout the year. The first exploratory measure is called the tuberculosis or TB risk assessment. And for this measure, we're looking at the percentage of members ages 12 months to 21 years, so up to the member's 21st birthday, who've been screened for tuberculosis risk factors by staff at the PCP office during the measurement year. We want to make sure that our members are being screened for risk factors, and only those with positive risk factors are being tested. So previously, we used to test often without establishing a risk for disease, but now we're asking for screening to be completed. And if the answers are negative, then there's no need to continue with the test. However, if a member does screen positive, then TB testing is required so we can treat and stop the spread of TB. This measure is the first line of defense against tuberculosis and is a part of the Bright Futures recommendations. We are looking for the screening of children because they tend to progress faster from infection to active TB and more likely to have a life-threatening form of disease like TB meningitis. Next, we have the lead screening in children measure. For this measure, we're looking at the percentage of children 2 years of age who had one or more capillary or venous lead blood tests for lead poisoning by their 2nd birthday. Our recommendation is to identify every child without a record of completing the blood lead screening test and provide the oral or written guidance to a parent or guardian relating to risk of childhood lead poisoning. A January 2020 report by the auditor of the state of California determined that millions of children in Medi-Cal are not receiving lead testing and that the CDPH is not prioritizing the prevention of lead poisoning. So what are a few reasons to check lead levels? Number one, exposure to lead in children can cause damage to the brain and other vital organs, as well as intellectual and behavioral deficits. Research also suggests that there is no safe blood lead level and its effects are irreversible. Since lead exposure at low levels that do harm may not cause any symptoms, at-risk children may not be identified and therefore would not receive appropriate treatment or environmental investigation. Next slide, please. And last but not least, we'll go over a few items in our resource section of our presentation before handing you over to our final presenter. We'll start by looking at the mid-year performance report that was distributed to our providers in 2020. So this report was created last July timeframe, allowing for an earlier look at your Q2 performance rates for the quality measures. So while we have you on the line today, we wanted to take this opportunity to let you know that the software has changed this year, so the report will look slightly different. The goal is for the Quality Improvement Department to still provide you with this information during roughly the same time year as we did last year. So I highly encourage you to be on the lookout for this report. Okay, as promised, this is a look at the new CBI practice profiles starting in Q1 of 2021. And the first thing that I'd like to point out is that we've really tried to clean up the profile in terms of repetitive titles, the overall look of the document. It just looks a lot cleaner. So I'll start off by mentioning the programmatic report periods from and to. It's now available so that it matches each quarter's rolling 12-month period. So for those of you familiar with CBI, you'll know that we do always look at a rolling 12-month period for our programmatic measures. This really does allow us to see the time frame that we're pulling in this data. So in this example specifically, we're actually looking at a Q3 practice profile. So what that means is we're looking at Q4 of the prior year up to Q3 of this year. Next, we've added the total programmatic points in the front of the practice profile. Historically, we've only provided this information on the last page, but we wanted our providers to have the ability to identify their points earned on the very first page. I know when I'm working with the provider, I typically thumb quickly to the last page to see how many points that they've earned, and now it's easily recognizable on the front page. Next, we have moved the plan benchmark and plan goal to the middle of the profile. Traditionally, we've always had the plan goal listed on the left side. Now we've moved it over slightly to make the profile easier to read left to right. So what does this mean when you get your first profile for Q1? I'm going to review just a little bit. So when you get the profile, it looks a little bit more streamlined. So if we start on the left-hand side of your screen, we're going to look at your measures for the year, how your performance is, your practice is performing. Then you'll look at your plan benchmark. Now, typically your plan benchmark is where you start to earn points. And then your plan goal is where you start earning maximum points. So as soon as you hit that plan goal and above, you'll start earning those maximum points for each measure. That's really important to remember. And then the last thing that we removed was the benchmarks group section that had those little colored blue boxes. So if you're familiar with CBI, you know exactly what I'm talking about. The eligible member or eligible per measure column now replaces the minimum member requirement. So instead, we've actually changed this column to represent whether or not you're eligible for the measure in terms of the minimum denominator requirement. So you have to meet a certain denominator requirement in order to be eligible for a measure and receive points. Moving on to the second page of the profile, where we have the quality of care measures, you can see that we kept the flow of the profile from the first page, and you'll actually see this throughout the document. So we have kept the plan benchmark and plan goal right smack dab in the center, just like we have on the first page. And that's really to keep our profiles really streamlined and easier to read as you're going through it. We've also added the percentile group, which is what I mentioned a couple of slides ago. In this column, providers can keep track of the percentile groups for each measure during each quarterly profile review. So you can really start to keep track of your performance in these measures. And then lastly, we have the eligible for measure column again. We did increase the number of eligible linked member requirements from 5 to 30 for each of the quality of care measures. The only element on page 3 that I'd like to point out is the plan goal has moved again from the left-hand side into the center of the profile to really keep in alignment and more streamlined throughout the document. So if you notice that on every page of your profile going forward, that plan goal is going to live right in the middle of your profile. The fourth page displays exploratory and fee-for-service measures. There's only slight changes made to this page. We did clean up the page to actually minimize redundancy, and we've updated 2 columns. So one, the service completion column, and the plan goal. So these are your exploratory measures. They will not be receiving payment for 2021, but it gives you an idea of how your performance is going throughout the year. And for the very last profile or last page of your profile, I did want to point out a few things. So the Q4 profile, some of you may have noticed that we added the risk stratification score just under the programmatic measure points, but that will only be available for your Q4 profiles, not for the first 3 quarters. So in this example, this is a Q3 profiles, which is why you don't see it on this page. If you would like more information on the risk stratification score, I highly encourage you to reach out to your provider representative. And last but certainly not least, we have changed the legend to include resources that are available to you. So we included the links to the CBI timeline, benchmarks, technical specifications, and a few other important resources that you might find useful when making improvements with your care-based incentives. I think it's really important to know where the resources live so you can access them at any time. So that is it for my section. Thank you all for joining me in the first half of the resource section today. I will now turn you into the hands of Kim Carmona to wrap up our presentation.
Thank you, Sarah, and thank you all again for spending your lunch with us today. We'd like to conclude our presentation by sharing a few updates, including new resources available for our providers. But first, I'd like to start off by saying we understand these are challenging times for many, including you all, our providers. We know you are all very busy, and since we can't meet in person, we've had to transition to videos for the purpose of providing education on process improvement. That being said, we are very excited to share the launching of our new Practice Transformation Academy videos, as shown here on your screen. I do want to say a lot of time and effort has been put into these videos, which you will discover were actually recorded at home by staff. So it is very exciting to be able to finally launch them for your viewing. As you can also see, these videos are part of a series titled The ABCs of Quality Improvement and were developed by our Practice Transformation Academy. For those who might not be familiar, we developed the Practice Transformation Academy, which includes quality improvement staff to provide both instruction and support to our providers with the purpose of improving the overall patient experience and outcomes. In line with this goal, the video learning series covers different process improvement techniques and workflows you may find helpful for implementation in your clinic. For example, the first video preview shown on the bottom left of your screen goes over how to write a SMART aim statement. The second video in the upper right-hand corner of your screen goes over how to craft a project charter and features my co-host, Sarah Ford. I make an appearance in the third video, which goes over how to use process mapping to improve outcomes in your clinic, bringing the content from the first 2 videos full circle. I'd like to note we actually have several videos in progress that cover other process improvement topics, such as using data and lean principles. These videos will be released at some point in the near future, so stay tuned. Now, let's take a closer look at where to find these videos on our current provider webpage. Here we see a screenshot of our current quality improvement page, which offers numerous CBI resources. You will have to follow the steps to get to this page and view the Practice Transformation Academy videos. Upon landing on the provider webpage, you will see a sidebar on the left as shown in blue, which includes various aligned provider links. Once you locate clinical resources as indicated by the number 1, you will see a list of subcategories or hyperlinks directly below. Make sure to click on Quality Improvement as indicated by the number 2. Once you are directed to our Quality Improvement page, you will need to click on Practice Transformation Academy indicated by the number 3 on your screen. But please note, we are also happy to share direct links to these videos after today's webinar with you all. Ultimately, we hope you and your staff find these videos informative and helpful. Please feel free to also share widely across your network, and as always, please reach out with any questions. The CBI and provider relations teams are happy to answer any questions you may have. Next, we'd like to share more information about a pilot project in the works, the Alliance's Provider Chat. The provider chat will be a forum for our providers to discuss ideas on how the Alliance can improve communication pertaining to our CBI program, specifically communication about our various materials, data, and reports. Topics of discussion will include CBI-related items such as workshops, webinars, and forensics, but can really include anything you would all like to discuss. Our ultimate goal is to make the chat an informal space where we can learn from you all, but also a space where our providers can also learn from one another, whether that's monthly, quarterly, or biannually. The provider chat is tentatively scheduled for the time being. And before we launch, we'd like to gauge interest in the chat, and we do have a quick 2-question poll to share with you all. Joe, would you please mind sharing the poll?
Absolutely. Here's question 1. Give you just another few seconds to answer. It looks like we have most attendees replied. All right, I'll close this poll, and we have one more. For about 10 more seconds to get a few more answers in. All right, polls are complete now. Kim, back to you.
Great. Thank you, Joe, and thank you all so much for your participation. We look forward to sharing more details about the pilot very soon. Next, we'd like to share information about an upcoming event, our Provider Portal webinar. As shown, please make sure to mark Wednesday, July 21st on your calendars. We anticipate this webinar will also take place during the noon lunch hour. Sarah Forbes will be hosting this webinar, offering a comprehensive overview of some of the reports found on our provider portal and best practices for improving CBI performance in your clinic. We will be sending an invitation with more details very soon, so be on the lookout. But just to add more detail, the webinar will go over using and understanding reports. This includes our linked member, forensic, quality, and high utilizer reports. Sarah will also be going over customizing and understanding the CBI dashboard, so make sure you check it out. We think you will find it highly informative and beneficial. And as always, please reach out directly after the webinar if you or any of your staff might be interested in attending or have any questions. We're happy to send you more information. And now let's move on to the last update we have for you all. After many months of hard work, we are thrilled to announce we are launching a new Alliance website. As an organization, the Alliance wanted to make the new website easier to navigate and more user-friendly. The ultimate goal of the redesign is to provide both our providers and our members an easier way to learn more about the many services and resources we provide. As you can see, the new site has a fresh look and is full of new features customized to meet all of your needs. For example, the site will include a direct link to the provider portal under the provider tab as shown here on the right. Another great feature of the new site will include a new CBI page, which will live in a slightly different location. To get to the CBI page, you will have to click on the Quality of Care link under the tab for Managed Care as shown on your screen here. Upon landing, you will be able to use several hyperlinks to access resources such as incentive summaries, technical specifications, and tip sheets. If you click on CBI tip sheets, you will see a drop-down list of our current measures appear. Now, let's take a closer look at the tip sheet for the asthma medication ratio measure listed here. After clicking on asthma medication ratio, we are directed to a new page, which also includes a drop-down menu. If, for example, you click on the eligible members, you will see a description of the eligibility requirements for this measure as shown on your right. Now, to help ensure the new site and new features are readily accessible and optimized for your needs, we do have a second poll to share. The poll is only one question and asks about your preferred devices. Joe, would you mind sharing the second? Oh, great, thank you.
I'll give about 10 more seconds for voting. So if you haven't, please go ahead and vote in the poll now. All right, gonna go ahead and close the poll out. Kim, back to you.
Great. Thank you, Joe, and thank you all again for your participation. We are very thrilled about the new website. We do anticipate it will go live this summer, July 1st to be exact. Now, let's move on to our final slide, key points and takeaways. In closing, there are a few key points we'd like you all to remember from today's presentation. First, don't forget to utilize both the CBI Incentive Summary and the Provider Portal to keep track of your clinic's quarterly performance and learn more about the measures discussed today. Also, we encourage you all to schedule a virtual visit to review your current performance. We do have a CBI forensics team specifically for this purpose, and you've already met the majority of the team. We are more than happy to meet with you virtually, at least for the time being. Finally, don't forget to view the Practice Transformation Academy videos via our current provider webpage. And if any of you are interested in practice coaching or would like to learn more about it, please use the email address on your screen to email the team. And now, I'd like to hand the presentation back to our co-host, to our host, Joe, who has one final poll to share. Thank you.
Thank you, Kim. Awesome. I will get to a couple last polling questions here in just a moment, but wanted to thank you guys for attending and point out that on your screen is the contact information for our CBI team, and the CBI email at the top of the slide is the best way to contact the entire team. As a reminder, your provider relations representative can also assist with questions and concerns. And immediately following today's workshop, you will receive a survey from us. Your feedback is extremely important to assist us in tailoring these workshops to best fit your needs. And with that, I'd like to ask you guys two more polling questions, and then we will go ahead and get to the Q&A session. Great, thank you very much. And the last polling question for today. Wonderful. Thank you guys so much for participating in our polls today. We really appreciate it. Again, the feedback that you can provide us with these polls and then in our survey really helps us be more equipped to help you. So without further ado, let's get to some questions. The first question looks to go to Kristen today, and it is, what is the calculation used to convert CBI scores into money? And second part of the question, how much is each point worth, and is there a way to speed up utilization reporting?
So that's actually, this is a fairly common question that we get from our providers. So in terms of how the CBI program structure is designed, at the end of the program year, the Board of Commissioners do approve the overall pool of money that's available for the CBI program. So in the December board meeting, it is presented from staff what we're recommending the program to be for the total allocated pool of money. And then that pool of money gets dispersed into the 3 comparison groups for family practice, pediatrics, as well as internal medicine. For the overall calculation within your comparison group, there's a couple of different factors that are used, and that includes your total member months that are associated with the practice, the risk stratification score, as well as the CBI points. And so this gets weighted across the peer groups, and it's a factor of those 3 different items. And in addition, you can also find some additional information in the CBI contract addendum, where it does discuss how the payment is allocated and dispersed across the comparison groups. In terms of the second part of the question, for speeding up of utilization reports, it is a challenge. It is something that we do hear feedback from our providers on. At least for the CBI reports, they are presented and distributed a bit later than the end of the quarter, which is why we do try to focus on having quicker deliverables for the provider portal of the monthly quality reports. So this is a way for us to do a bit speedier in terms of providing the information. So we do try to create a monthly quality report that's available because the CBI program itself does have a significant number of checks that are in place to validate the information, make sure that it's correct. We have about 33 different steps that are involved in our process to make sure that the CBI data looks okay, involving different departments that will also review and ensure that the data is placed in the appropriate place. So at least at the moment, we do have that delay for the CBI data, but in terms of monthly data, we do try to put as many of our reports that coalesce into the provider portal quality reports, and that those quality reports are more reflective of your total population because it's everyone that's linked to your population that then meets the denominator requirement.
Awesome. Thank you, Kristen. Kind of a follow-up on that to you as well, Kristen, is how has the formula for awarding incentive amounts changed?
Sure. So new to the CBI 2020 program, there was a change in terms of how the awarding is distributed. So it's similar to what I discussed earlier, is the risk stratification score is the newer component in the program. What we used previously was a weighting factor based on the practice's linked SPD population, and that was a calculation based on member months times your SPD population, but we have switched for the CBI 2020 program moving forward to use this risk stratification score, which is basically derived on your members' demographic information like age and gender, as well as diagnoses that are submitted to us through claims.
Thank you so much. Switching over to coding a little bit for Sarah, what are the ICD-10 codes used in the program?
This is a really great question. So thank you for whoever asked that. So we do have ICD-10 codes that are hyperlinked within our technical specifications. Or technical specifications document is a rather large document that actually details each measure. It breaks down every component, which also includes the ICD-10 codes that are included in the program for each measure. So what this includes are codes that are brought into what actually brings a member into the population or into the measure, what excludes them or takes them out of the measure, and then what makes them compliant. So if you have any questions or need access to the technical specifications, please feel free to reach out to one of us, and we'll point you in the right direction.
Thank you very much. Question about data and it being extracted for CBI. Two-part. How is the data for CBI extracted, and how do smaller practices with less members compete in the CBI? Kristen or Sarah would want to take that one.
Sure, I can take that question. So data is actually extracted in a number of ways. So what we do is we compile information gathered from laboratories that we have actual active data exchange processes. We look at claims data, DHCS encounter data, lead information from DHCS. We look at immunization registries. We have name matching processes that happen on a monthly basis, as well as through our data submission tool for information that could be conveyed in a claim or feedback from providers that have challenges in dropping into the billing system with their EHR design. So we're happy to meet with all providers. And for smaller practices, we have met to train on submission of data gaps through the data submission tool. So we've also helped to walk through more of the nuances of the CBI program in a more one-on-one setting with providers. This would be typically known as a CBI forensic visit. Smaller practices do have a smaller denominator population than the larger practice sites. And so we do, as Kristen mentioned with our CBI or our quality reports, one of the recommendations would be to start extracting that data and working off those lists as recall data as well. Kristen, did you have anything to add?
No, that's perfect, Sarah. Thank you.
Awesome, wonderful. I did have a quick request to repeat the 3 factors that are included in calculating points to funds.
Sure. So the 3 factors when you're looking at the pool of your comparison group is to look at member months that are associated with your practice, which you can find on the upper right side of your practice profile. The risk stratification score, which Sarah mentioned, is only included in the quarter 4 practice profile, and that's located at the back of the profile, as well as the CBI points. So it's a factor of these 3 factors, as well as what is those 3 factors across your peers in your comparison group.
Perfect, thank you so much. Okay, so some more questions that came in through the chat. Are there any plans to increase the cadence of the utilization metrics, ACSA, post-discharge care, et cetera?
At the moment, I know that we've been focusing on the quality of care measures. So there's a number of reports that we have already submitted to our programmers in terms of active tickets that we're just waiting for them to be picked up. So I know one of the ones that's high on that list is the child and adolescent welfare visit, since the transition of the measure went to this more expansive measure. That's one of the reports that we want to have up. For the hospital and outpatient measures and access measures, I know we've talked about putting in like fluoride varnish. For the hospital related reports, I would say the best way to kind of judge those on a more monthly basis or even weekly or daily is to utilize the linked member report. So there's a e-census data that's generated to us through participating hospitals that will provide emergency department use as well as inpatient stays. So you could utilize those linked lists to see of your linked patient list, when did they come into the hospital, what were the diagnoses that were sent using those e-census data. So that's one way to get more utilization data for those measures. In the same way, for the post-discharge, you could use the ED roster to make sure that you do those call outs in terms of follow-up phone calls to ensure that they have a post-discharge visit scheduled within 14 days of the release from the inpatient stay. We'd have to take back whether we can create a post-discharge report specifically, as well as some of the other ones. But at least for the moment, you can use the linked member list to follow the hospital e-census data for some of that information.
Wonderful, thank you so much. Okay, so going to telehealth, Kristen, this may be appropriate for you to answer also. Can you clarify what remote monitoring for BP means? I.e., if you have a phone visit with a patient and they self-report their blood pressure using a home BP device, does that count? And if so, do they enter that information into the EHR?
Yeah, so this has been a really interesting one because with the pandemic, telehealth has become more normalized. It's been more accepted. We slowly watch for the different types of visits to then be coded differently and have that information sent in. From the perspective of the state, one of their main phrases was that it's up to the discretion of the provider whether or not they want to accept that self-reported information. So there's a couple of new codes that became benefits in 2020 specific to remote monitoring, which we can include in our Q&A information that gets posted with the webinar video on the training page of our website. So I can provide some additional details there, but primarily from the perspective of the Department of Healthcare Services, it's up to the discretion of the provider in accepting that type of data. So there are codes that have become Medi-Cal benefits that you can use for the recording only, scanning analysis with the report, review and interpretation of the report, and I can share that information in the FAQ that's posted.
Wonderful, thank you. Yeah, I think additional follow-up would be great on that. So a couple questions that came in about fluoride varnish. So Sarah, I wanted to direct them your way. For question is, where do practices usually get? Second part is, how much is the dental fluoride varnish per unit usually? And I understand if that second one is not something you may be versed on, Sarah.
These are really great questions, and I will get back to the provider about this on later during the FAQ because I'm not entirely certain. This was part of Kristen's review, so I'm not sure if Kristen has any additional thing to add.
Sure. So in terms of where you would get fluoride varnish, the training as well as the actual material, you do have to go through your local CHDP office. So that's something that would have to be set up with them, and we can include their information in the FAQ as well.
Wonderful, thank you. And how do you measure TB risk assessment? we can provide information on that in the FAQ as well. But if I wanted to open up the floor, if Kristen, if you wanted to explore on that. Thank you.
So in our fall webinar, we actually explored some of what that exactly looks like. So there's a couple more examples that we shared in terms of the screening tool. So there's one that's developed, I believe, by the state that we included in that webinar that has a set of questions to go through the screening, and we can provide that information as a follow-up.
Thank you so much. Switching to the DST, is there a deadline each month to submit supplemental data through the DST for it to be incorporated in the following month's report?
Yeah, so I can answer this. Sorry, I couldn't get off mute for the last question, but for the DST, typically, if you provide this information or you do your submissions, I would say about the 20th of the month, you should be safe. We do start to extract data to pull in for the next month around typically the end of the month. So I think the 20th is a safe bet. So don't not submit data after the 20th. It will still be counted. It'll just have to be it'll be in the following month, not in the next month coming up.
Wonderful, thank you. And it looks like we have real quick for one last very quick question. Kim, this will be for you, and it is, when is the go live date for the new website?
Thanks for that question. The expected live date is July 1st.
Wonderful, thank you so much. And another question that came in that I'm happy to answer is, will this presentation be shared with attendees? And the answer is yes. We will be able to send you a recording of this presentation today, along with the FAQ that Kristen had mentioned. So all the questions that we were able to answer, and I believe a couple came in that we weren't able to, we'll get those sent out in an FAQ and the recording. So this concludes the questions for this afternoon, and any more questions or topics you feel important to discuss, please contact your provider relationships rep or your CBI team. Contact information is still on your screen. And once again, after this webinar, you will receive an email and a survey from us. Please take a few moments to fill that out and provide your feedback. And then you will receive a follow-up email with the link to view a recording of today's webinar and that FAQ we were talking about. On behalf of Central California Alliance for Health and our presenters, thank you for joining us this afternoon, and have a great rest of your day.